Good afternoon, ladies and gentlemen, and a warm welcome here from Cape Town. It gives me a huge pleasure to welcome my co-presenter, Professor Steve Jeffrey, and it's lovely to have him. And of course, it's even more lovely to have Dr. Bhavi Vithalingam, and she is a mental health specialist. She has been on this forum before, you'll remember over there. As you can see her cum laude, she's come cum laude for her psychiatric exams. She's also started the Women's Mental Health Program, at Curtis Care Hospital, and she's on the executive committee of the Women's Mental Subgroup of SASOB. Bhavi, can you hear us, Bhavi?
I can hear you perfectly, and I can see you. It's really nice to see and hear you guys.
I see. You're sitting there so deadpan. I was wondering if you... I was wondering if you...
The photograph.
Yeah, I thought it was a photograph. But I see it's actually you in the...
It's the psychiatrist face. We don't show
I
emotion.
know you
Come on.
don't show it. It's what I call a poker face. But also, you're regional coordinator for the International Marche Society. Can you just give us 1 minute? What is the International Marche Society?
So
What-
the Marche Society is an international society that focuses on perinatal mental health. So mental health during pregnancy and mental health during the postnatal period. And it's a society for clinicians, for researchers, for advocates. It's really just a broad-based society for anybody interested in perinatal mental health.
Oh, thanks very much, because Bavi and I do share patients, Steve, and it's a huge problem, the postnatal depression. You know, you get baby blues and you get postnatal depression, and it's next level psychiatric emergency, that. And it's a great pleasure to have you over here. Thank you to Corin for setting this up. Our sponsor is the Pelvic Floor Foundation of South Africa. Excuse me. And Steve, can I have that piece of paper back, please? Because I just want to tell you about next week. Next week, ladies and gentlemen, is contraception. A look at the options in making contraception work for your patients. And that's Professor Zozo Nene, and that's sponsored by Bayer. So, ladies and gentlemen, remember we have MCQs, multiple choice questions. You've got to get 70%. They're not difficult. I know they're not difficult. It's not that difficult to get your CPD points. This afternoon, our topic is burnout and impairment in doctors. And I mean, burnout and impairment is a real thing. It's beyond a problem over here. Sometimes I wake up in the morning and I can't get out of bed and I think I've got burnout. But I think this is actually worse than that, Steve.
Yeah, I think absolutely. And
Yeah.
I mean, it's obviously a conversation that never doesn't get had. So it's an important subject that we should be opening up and talking about. And yeah, and also finding that distinction. I mean, I think most obstetricians would feel a bit of burnout. I mean, if you wake up and you've had difficult deliveries and things.
Well, my problem is I get to bed at 3 o'clock in the morning and I can't get out of bed because I'm burned out. So
just too tired.
I'm just too tired. But I mean, I don't think
really
that's what
burnout.
Bavi.
Yeah.
No, I don't think. I think that's just being tired. So, Bavi, without further wasting of time and discussing, are we burnt out or are we just tired? Burnout and impairment in doctors, Dr. Bavi Withlingam, and thanks again to the Pelvic Floor Foundation for sponsoring this.
Thank you.
Okay, so I'm just going to share my screen, which is that one. I hope that you can see it. I'm just going to start my slides.
I've got it now.
Perfectly.
Got it now.
Okay. Where is the slideshow thing? Hang on, there we go. So I'm going to talk about burnout and depression and other mental health issues in doctors, but I'm also going to talk about impairment, and I'm going to talk about how we as doctors actually treat other doctors. So we're just going to look in general at the wounded healer. And you may wonder who Asclepius is. And Asclepius is actually the original god of medicine in Greek religion and mythology. And he was the son of Apollo and Coronis. And he was really one of the first healers and gods of healing. He didn't start off as a god. He became a god through his prowess in healing. And I just thought we would remind us of where some of our roots in healing come from. I'm going to start by talking about healing your peers, because I think one of the biggest challenges to us is around healing our peers and actually contributes to a lot of burnout. I'm going to look at some of the ethical issues involved. And then I'm going to talk about the impaired practitioner. And I think the impaired practitioner is a huge issue for us across all our specialties and presents significant challenges, both if you are an impaired practitioner, but I think also it's very difficult when you as a colleague have to say to your colleague, listen, I think you're impaired, we need to do something about it. So let's just start off by looking at a case study. And these are all based on real cases. So Adele, who is 28 years old and is a registrar, comes to you because your colleague, her consultant, has become ill. I'll tell you, her consultant sends her because she's now become ill. And in my field, obviously, she's become mentally ill. She's usually depressed or she's anxious. But let's look at some of the challenges that we might face in dealing with Adele, because Adele might come to you because she's pregnant or she has a pelvic floor issue or something else. So the one issue that really comes across is confidentiality. How do we keep are doctors' records confidential? And this is something that's enshrined in the South African Constitution. And when I think of confidentiality, I think of many things, but with specifically regards to doctors, the one thing I think about is a waiting room. And then the second thing I think about is note keeping. You know, I think we may all be tempted when seeing doctors not to keep the same notes that we would for any other patient. Especially if there's sensitive information that has been divulged. For example, if you see a practitioner and that practitioner has a sexually transmitted disease, or it comes out in the consultation that the practitioner's spouse, who is also your colleague, is having an affair. In my case, you know, is the person depressed or anxious? Is there alcohol abuse? Is there drug abuse? But the HPCSA is absolutely clear about the fact that we have to keep decent notes for every single patient, regardless of whether they are practitioners or not. And you can see in the slide things like the biopsychosocial history, the medication proposed, other referrals, just as we would for any other patient. You know, it can be tempting, especially if somebody just pops in to see you, you know, not to make notes. But both for that patient and to protect yourself, you should keep good notes. So moving on with Adele was referred by her consultant, and her consultant requests feedback on her progress. And the question is, should you respond? I get this often. I see a lot of doctors, and I see a lot of registrars, and I see a lot of interns. And very often somebody is referred to me, and then I'm asked for feedback. And the question is, what do we do? And again, here, the big issue is confidentiality, because I think that we need to understand that when a registrar or an intern or a junior colleague is sent to us, it's more than just feedback to the referrer. Essentially, what we're giving is feedback to an employer. If you see a registrar and their consultant asks for feedback, that's the employer. That's not their treating doctor. And very often there is, you know, conflation of roles. As doctors, you know, I think we're just generally really, really caring people. And when we send our juniors for help, we do it because we care about them. And we want to know what's going on, and we want to help them. But we need to recognize that, you know, if in the state you're the employer, if you're a senior colleague in the private sector, you're still a colleague. Unless you're actually treating that patient, you shouldn't be getting feedback. And if we are the treating doctor, we need to look very carefully at the purpose of the feedback and how appropriate it is. Why does the doctor want to know this? What's going on here? It's different if it's a very clear referral. For example, this morning, I saw a young doctor who was referred to me by one of the senior general practitioners that I work with. And of course, I wrote a letter back because that's what you do. But if she had come from her consultant, I would be hesitant to do that because of that conflation of roles. So now moving on to Adele, who is a doctor. She asks you to code her diagnosis as a less serious diagnosis. So we often get this. Patients say, please don't submit to my medical aid as depression, submit it to the medical aid as an adjustment disorder. You may be asked in your profession not to disclose certain things in terms of diagnostic codes because patients are worried about their confidentiality, they're worried about the impact on their future insurance, they're worried about, you know, stuff getting out. I think as doctors, we all worry about our professional reputation. As doctors, our reputation is really everything. If we don't have a good reputation, what do we have? So we worry about the diagnoses. But Adele clearly meets the criteria for the diagnosis that you've given her. And the question is, what do you do about that? Do you write a different diagnosis? Do you write what you think it is? And I think it's important to have that discussion with your patient to say, listen, This is your diagnosis. Your diagnosis is depression. Your diagnosis is that you have a sexually transmitted disease. Your diagnosis is that you have pregnancy-induced hypertension, whatever. That is what your diagnosis is. And I can't not write that when I submit to the medical aid, because actually that's fraud. If we write the incorrect diagnosis, we are committing fraud. If you don't want me to disclose your diagnosis, then we can't do a medical aid submission, and we have to talk about some other way of payment. And I'm going to talk quite a bit about payment later, so I'll leave that for now. But it's really important as doctors that we write, and not just for our colleagues, for any patients. Patients often ask us to say, oh, just write this diagnosis, please, because it's a PMB condition, and then I can get PMB benefits. And it's tempting because, we feel for patients. We want them to get benefits, but it is actually an illegal act and it puts us at risk. So let's look at another doctor. Dr. M is a very well-respected GP in your area. She often refers to you. Several of her patients attend your practice, and Dr. M wants to come and see you. And the question is, should Dr. M be in the waiting room? Should you make her wait with the other patients, some of whom may be her patients? Should you do something different? And the first question is, should you be seeing Dr. M at all? Because can you be objective with somebody that you know? It's slightly different for us because of the nature of the work that we do, but with any patient, how can you really be objective? But what happens if you have an area of special expertise? So my area is women's mental health. What if Dr. M is going through menopause and is now depressed and wants to see me to discuss this? What if Dr. M is seeing you because of your expertise in the pelvic floor area? Maybe she's pregnant, she needs special obstetrics care. Should she wait in your waiting room? So I actually had this experience last week because I had to have a scope. So of course, there I was sitting there feeling like awful because I'd done the whole prep thing the day before. And who plugs themselves down next to me but my patient, who wants to have a lovely discussion about why I'm here and how did I find colon prep. And it was just the most uncomfortable experience. I actually just made an excuse and went and sat outside in a different area of the hospital. But what can you do? So you could check that the patient's appointment is not directly before or after her patient. And we try and manage this not just for our doctor patients. We do it for our schoolgirl patients as well, because you don't want two girls in grade 8 knowing that they're coming to see you. We try and schedule our doctors for the first and last appointment of the day or at another time when your practice is quiet. It's not always possible. We're all busy. We can't keep those appointments free. And when I did this presentation at another forum, somebody says, well, why don't you allow Dr. M to wait in the tea room? And we had a lot of discussion about it, but most of us felt that when you're seeing somebody as a patient, they're a patient, and it's important not to muddy those roles. So you really should maintain boundaries in the doctor-patient relationship. And boundaries link to burnout, because a lot of burnout with doctors happens when we don't maintain those clear boundaries. And you know what? We do this again because we care, because we're trying to help people. So we see people maybe later in the afternoon when actually we would have closed our practice and gone home. We fit people in early in the morning because they can't come at another time. We find that we're taking calls well into the evening. And I know you've all done this because this is what we do. We get up from our supper because somebody has called us. So we say to the kids, just hang on a second, we've got to take a call. So keeping that boundary is really important to make sure we don't burn out. And one of the things we have to look at is, does it really matter who the patient is? Should the patient's background manage the clinical condition? So let's see what some of doctors have said. So this is William Osler. You may remember him from Osler's Nodes and a whole lot of other stuff. And Osler felt very strongly you should care for the individual patient, that who the patient was very, very important. Hippocrates said that you should hold your teachers as dearly as your parents. And those that he taught him medicine should be as dear to him as his parents were. The General Medical Council clearly says doctors should not treat themselves, and wherever possible, avoid providing medical care to anyone with whom you have a close personal relationship. And that's across the board for all doctors. We shouldn't provide medical care to anyone where we have a close personal relationship. But on the other hand, no professional body says don't treat an ailing colleague. In fact, they say we should treat ailing colleagues. And the question is, what is a close personal relationship? So, I mean, I think we would understand that our sister or our spouse or our associate with whom we share our rooms, these are close personal relationships. But let's look at Dr. M. We have a working relationship with Dr. M, as many of you have with colleagues. We have working relationships. They may refer to you often, but we're not friends. We don't go out with them. We don't socialize with them. Does that constitute a close personal relationship? I don't think it does. Other people do. We also have to look at our South African context, where medical circles are really small. I mean, most of which know each other. I mean, I know Peter, we share patients. Stephen, I know not well, but we know each other by reputation. We've bumped into each other in the hospital corridors. I mean, certainly among specialists in a given city, most of the specialists will know each other or know of each other. And how do we manage that? How do we then not treat people who are close to us? So one of the things I want to talk about is very important patients. And very important patients are also very important in leading to burnout. So we have to be aware of them. And all of you will know the Kardashians. And the Kardashians meet the criteria for very important patients. Thank God we don't have them here. I mean, can you imagine treating a Kardashian? How awful that must be. To those of you who are fans of the Kardashians, I apologize, but really, I just think it must be awful. So
I'll be on this point. I saw a patient yesterday who disappeared to go to the toilet, and she took quite long to come back. And then she said, sorry, it took quite long. Someone was asking me for a selfie. And
oh my God, who was she?
My
I suppose you can't tell me.
went out there. They said, so-and-so was here and was some famous actress.
Oh.
It was all right. Anyway. So sometimes some of us aren't actually aware if someone's a VIP.
Well, I'm not on social media at all, so I'm completely clueless about these things. And I've had very important patients and not known who they were. And they were quite offended that I didn't know who they were. But a patient is anybody who's been able to exert through personal influence or professional status unusual pressure upon the hospital staff. Anybody that makes you feel intimidated, where you get anxiety, tachycardia, where you feel and we all do. I mean, there are those patients who do make us feel intimidated. And it may be because they're famous, it may be because they're doctors. I mean, I had one patient who was the wife of a very influential gang member in Cape Town. And quite frankly, she terrified me. And I was really, really glad when she went to go see somebody else. And the problem is that they have the potential to influence your judgment or your behavior. We may behave differently around very important patients. And when a very important patient receives non-standard treatment of care, and that gives them worse outcomes, we call that VIP syndrome. And this is a particular problem when treating doctors, in that they may actually get worse care because we're treating them differently. So some differences are that we give people personal contact information. We avoid uncomfortable testing. In my line of work, we may not drug test the doctor, and actually we should. I'm sure there are lots of uncomfortable things that you do that you don't necessarily do for the patient, where there's this pressure on the treating physician to do stuff like waive routine admission procedure. I'm not going to sit downstairs with the clerks. I'm going straight up to the ward. Communication with the hospital manager. You come to see your patient and you've discovered that they've chatted to the hospital manager and things have been moved around. Private rooms, unique visiting hours, special diets, these are all things that very important patients attempt to get or do get.
Baby, can I just pick up that one point you said? You said that you are not allowed to do drug tests on doctors.
No, you should do drug tests on doctors, but often people don't because it's uncomfortable. Yeah. You really should do it. I mean, if you suspect that there is a drug problem, you should do it. But very often doctors get away with it because we're uncomfortable about asking about drug use. You know, I mean, it's not comfortable to say to your colleagues, do you use drugs? Are you using cocaine? Are you using meth?
Which you're allowed to. It's not against the law.
You have to. You absolutely have to.
Okay.
You know, as if you're a psychiatrist, you must definitely do that because it's part of your evaluation.
Right.
So we talked about differences in medical record documentation, communication of results. You know, you phone your colleague, special scheduling. And this for me is a big problem, engaging the physician-patient more in the treatment decision-making, which may or may not be a bad thing, but it has the potential for abuse because when someone comes to you, they're a patient. If I come and see you, I'm not the expert, you're the expert. And I'm not objective because I'm sick. So while I understand maybe more than the average patient, I still need you to make that decision. But doctors don't like that. You know, I mean, as doctors, we want to make our own decisions, so it's difficult. But shouldn't doctors get perks
Yeah, I've
for
actually, I'm sorry to bother about interrupt, but you know, I've often thought about this. You know, there's always this theory that, you know, if it's an important person, there might be more surgical complications. And I think sometimes when you're doing an operation, you kind of stop your routine and start doing something differently. You know, maybe check once or twice about bleeding, stop fiddling a bit more, and maybe cause more problems. So, you know, I think the important thing is that you kind of fall out of your rhythm, and that's when people then start to get more issues as well. So I think there certainly is a different level of care, for better or worse sometimes. I don't know what you
But Steve, isn't that natural? I mean, when I, for example, operate on a lawyer, and I did that this morning, I'm always a bit scared because maybe I try too hard, I do something extra, maybe check for more blood bleeders.
Yeah,
because you know, if something goes wrong, she is going to sue me. I know she's going to sue me because she's a lawyer.
She's already told you she's going to sue you.
Yeah, and that's what they do. So I think it's very difficult to escape that. Otherwise, just say, I don't operate on lawyers and I don't operate on, we had this talk the other day, we don't operate on Jehovah's Witnesses. So, yeah, it's not as easy as it sounds, isn't it?
It's not easy at all. It's really not easy at all. It's a real challenge to just keep to your usual state of business and state of practice and not be involved in this. And the question is, shouldn't we get special privileges? I mean, why shouldn't we get special privileges? We doctors, we work really, really hard. You know, shouldn't we get something back from that? On the issues of professional courtesy, you know, we all take care of our own. It's part of what we do. And there's this natural extension of knowledge where doctors do know more. So I think the challenge is to give the doctor the professional courtesy and that care. And I think we do give a bit of extra care, but not let it impact on the quality of care that they receive. I'm just going to skip that in terms of time. And this is where the burnout stuff comes.
Skip that one, because what do you think about payment? I mean, that's always.
I'm going to get there. I'm going to get there. Don't worry. I've got a whole slide on payment.
Good.
So the problem is that when you treat a doctor, and I'm treating a colleague's daughter at the moment who is a doctor, so it's like double jeopardy. You feel stressed, you feel awkward, you feel judged. There's a lot of pressure not to disappoint your doctor-patient. And keeping the doctor-patient role intact is difficult. You don't want a reversal of a situation where they're telling you what to do. You need to be the doctor. Sorry, that was the wrong slide. So some do's and don'ts: document everything. Don't have curbside conversations. You know, try and keep it that you talk to the patient in your rooms. You make it a more formal thing. And I think a big one is don't assume anything about what your patient knows, because often we think that patients who are doctors know a lot, and they do, but they may not know your specialty, and they may not know stuff about their specific condition. So it's really important to give knowledge as you would to any other person, and be really aware of the fact that the doctor-patient is really often a bad patient who skips follow-ups, self-treats, does all sorts of things, and you have to be quite blunt with them and tell them not to do that. So this is quite simple.
Just something I'd also like to say. You know, I think sometimes you find yourself treating a colleague's family or you know, someone closely related, and I always make the point of telling those patients, especially post-surgery, that I always tell the patient themselves that remember, I'm your doctor. Because even for some simple things like analgesia, post-op the odd post-op complication, you know, it's often where that boundary can get blurred, where the person will say, well, what about pain? And just so the patient also understands that you are completely accessible and that they do need to remember to come to you rather than to whoever else is around. You know what I mean? So I think that I find quite important.
I think that's such a key point to make.
Yeah.
And I just want to, I think you've all read this slide, but I just want to say you want to leave plenty of time for discussion. So because doctors have more questions. Doctors know more, we ask more, and I think doctors are more concerned in a lot of ways. You know, we've seen complications, we've had bad experiences. Our bad experience may not be a true reflection of what has happened, but it's difficult to get over that. And I think you know much better than I do many doctors who won't have a normal delivery because of what they've seen during their training. They instead want a cesarean section. And I think it's important to discuss everything in detail. And I think it's really important to discuss issues of privacy, confidentiality, and payment. And I'm going to get to payment in a second. You know, you want to ask your doctor patient, who can I talk to? Which of your patients can I talk to? And be professional and courteous at all times. If you are too anxious to do this, and I think, you know, Stephen and Peter, and for you guys and I, we've done this business for a long time. I think that we're confident enough to be able to handle doctors and set the boundaries with our doctor patients. But for more junior colleagues, it might be too intimidating. So if you're feeling too intimidated, if you're feeling too anxious about it, walk away, find someone who's willing to undertake the responsibility rather. And as a general rule, you know, it's always easier to get somebody who's more senior to the doctor than they're treating. It's not always possible, you know, sometimes your professor gets sick and you have to do it. But if you are too intimidated, just don't treat the doctor. And payment, the big question. So let's look at a couple of scenarios. Now, this is a doctor we all want, doctor who's got Discovery Classic Comprehensive and very good gap cover. This is great because, you know, your bill's going to get paid, you know, and this doctor, I'm sure, will have no problem with you claiming for medical aid because everything will get paid. What about Dr. B? Dr. B's a junior, well, we hope it'll get paid. Dr. B is a junior doctor whom you've never met before, who comes into your practice for the first time and has a really basic medical aid. Like, you know, I'm not going to name and shame medical aids, but you know what those basic medical aids are. And it pays out well below your rates. Then you have Dr. C, with whom you have a passing acquaintance who actually has no medical aid whatsoever. And then your very well-respected Dr. D, who just has a hospital plan. I'll treat you for free, love. So, I mean, I think everybody has to have their own personal practice around what you do around payment. But I think it's really important to think about how you're going to charge doctors and have a standardized plan. It can be in your head that you stick to. So for me, I see a lot of doctors. If it's a colleague that I know and that I know well, I will bill to their medical aid. I will take what their medical aid pays. If their medical aid doesn't pay me, I write off the bill. If it's a doctor that I don't know, and I see a lot of doctors that I don't know, I never used to charge them. And then I realized actually it's not financially viable for me not to charge all the doctors that I'm seeing. So if it is a doctor that I don't know, if I will treat them as another patient. We try to bill as much as possible to medical aid, but I mean, if it's an ongoing, and we see our patients for a long time, if it's a really ongoing thing, then we will then say to the doctor, we charge to medical aid, and you just put in a co-payment. For my well-respected, very close colleagues, there are some people who are very close to me. Either they are very close to me because they've taught me, or I see their children, and these are very close colleagues. I do not bill at all. I do not submit. I don't do anything. That is my giving back to the people who did so much for me. That is my personal thing. You have to know what your personal thing is. There is absolutely no right and wrong in how you bill. But just my one piece of advice to you is be consistent around your billing for you. And, people may say, but why bill? Why bill doctors at all? I mean, because we get paid. I mean, it's money. We have bills just like everybody else. We have kids to put through school. We have rates to pay. We have bonds to pay. But also it's important to charge, in most cases, to charge something so that your services are valued. When we do not charge people, it is a well-described psychological fact that they don't take you seriously and that they don't value your services. So it is important to charge something. Okay. The other problem is that if we are not paid and we put in a huge amount of effort into a patient, and we all know that there are those patients who are complex and you do lots of stuff for them, you do end up feeling a little bit resentful. It's normal. We're human. And that spills over into the doctor-patient relationship, and that can create problems. And lastly, I think it's really important for us to recognize that time where we are not paid is time that is lost to our families and loved ones. I am very clear about this. And when patients ask me why I don't give out my private cell phone number, why I don't take calls after, if I'm on call, obviously I'll take a call after hours, but if I'm not on call, I don't take calls after hours. I don't take calls over weekends. I don't consult on weekends. My answer is simple. I have a family. I have family time. Family time is important to me. And actually, I can't get paid enough to take me away from my family on a weekend unless I'm on call. So it's important to put payment into perspective. Payment is an important validation of our services. It has very practical things. We shouldn't feel bad about getting paid for what we do. I think we feel that sometimes, medicine is a calling, and we get sent this message that medicine is a calling. I think medicine is a great profession. I think you have to be a very special person to do medicine. I don't think doing medicine is like being a nun, which is like a religious calling. I do think we should get paid for what we do. I want to talk a little bit about what happens when the doctor becomes a patient. And I think it's important for us to understand this because it is very, very hard for doctors to become patients. And these are some quotes. It's so hard to accept when you as a physician become a patient. This is for all patients. I mean, these are actually cancer patients who are talking about what it's like to be a doctor and have cancer, and then have to be the one that is not in control, the one that is not the expert, and have to hand it over, and to be cared for, because lots of our internal stuff is about the fact that we are carers and we care for other people. So moving on to burnout. Burnout has three big things: feeling emotionally overextended and exhausted by work, depersonalization, cynical, negative. You walk into the room, and I think all of us have been burnt out at some point or the other. So I think you'll know this feeling. You get there and you think, all right, one more, two more, or whatever more, then I can go home, And it's not that you feel that sometimes. It's a persistent feeling of just, let's just tick it over. Let's just get through the day. Let's just go through these patients. And a lack of a sense of personal accomplishment. What am I doing? I'm not doing anything. I'm just sitting there. I'm just an object. And one of the big factors contributing to burnout is something called moral injury, which you may have heard of. A moral injury is when you feel somebody's really violated your conscience, when you're forced to doing something that is against your moral principles. And we are forced to do this all the time. The insurers, the hospital, the healthcare system, the medical aides make us do things that go against our moral grain and our moral fiber. We have to, how many times have we offered care that we don't think is the best care because the medical aid won't pay for it and the patients can't pay for it themselves? I don't think you guys have this problem as much as we do, but our patients get 21 days in hospital and then we have to discharge them. So tomorrow I'm discharging a patient who is suicidal because her medical aid won't pay for her care, and she can't pay to stay in a private hospital, and she doesn't meet the criteria for certification, so she can't go to a government hospital. I think you can see how much it bothers me that I have to do that. And the problem is that when we feel the sting of moral injustice, it leads to burnout. And the problem is that it's about being, it's out of our control. Because there's a large body of research that shows that burnout really occurs because doctors, physicians have to face situations that are beyond their control. And I mean, of course we do in our setting, you know, we're not God, we can't control it, but it's usually about financial constraint or administrative constraints that are actually beyond our control. And that leaves us feeling in a place of helplessness, and that leads to burnout. What about other factors leading to burnout? Sorry, I mean, I wrote this for psychiatrist burnout, but it actually applies to everybody. 69% of people cite the bureaucratic tasks, the admin tasks, and think of what we're being forced to do more and more. I mean, 10 years ago, I didn't really have to write reports for medical aids. I've got 5 reports sitting in my inbox that came in this morning, and every report is going to take me half an hour to write, at least. I mean, it just goes on and on.
Can you not, nowadays with ChatGPT and that, can you not use artificial intelligence to write it? And I mean, they write beautiful reports, these ChatGPT and similar AI programs. Can't you in some way harness that app to help you?
That's a really, really good question. And it's one that we discussed at our last Congress. Should we be using ChatGPT to get us to write reports? I think for us specifically, part of the problem is that our reports are very specific to the patient. There's a lot of patient detail that we have to put in. And then there was concerns around confidentiality, because we don't know how confidential ChatGPT is. There are AI programs being written for medicine which maintain confidentiality. So I can't remember the names. But that was one of the big concerns raised around ChatGPT, not just at our conference, but there have been papers published about, is ChatGPT in medicine confidential enough and secure enough for us to use it, putting in potential patient data? Because there have been data breaches with a ChatGPT. People were using it to analyze hypertensive data, and there was a breach where the patient's confidential information was in fact revealed. And that didn't have a bad consequence as far as we know, but still it was a data breach. But
Because it's not that I use it, it's just that when I write these reports to medical aids, I wonder if I'm also not breaching POPI Act, because we're just doing it for some clerk and we don't know who's reading this report and what they're doing with the report. And, you know, is it ethical and right and moral for us to tell some nameless clerk in Discovery about some HIV positive woman and her, for example, her abusive husband and partner, that sort of thing? Where do we draw the line in terms of that? And there was that famous case in Finland of this breach of confidentiality where many women, in fact, committed suicide when that chap, do you remember that recently when he was sentenced to 6 years in prison he was a hacker of about 18 years of age. These things do happen. It's not theoretical, and it happens today.
It happens. Yeah, no, I mean, and that I think again contributes to burnout, because again, it's a moral injury. Why should I write all these details for a clerk to read? I mean, I have to do it. I have to do it because to get my patient the medication that they need, or the days in hospital that they need, or the procedure or whatever, and my patient is actually asking me to do it and is consented to do it. So, you know, technically I'm covered, but morally, I mean, and then what do I write? What do I redact from this? It's a complex task, and I think it really, you know, it sits with us.
Yeah.
I mean, things that
we have it often. I mean, sometimes you have to tell white lies and not so white lies just to get it. There's an example is that some medical aids don't cover laparoscopies. And if a patient wants a sterilization are you morally able to do a laparotomy for a
Sure.
procedure which should be done laparoscopically? That's just an example.
No, I agree with you 100%. I mean, one of the motivations that I have to write is I did ECT, electroconvulsive therapy, on a patient. And her medical aid is asking me to justify why we had an anesthetist. I mean, it's illegal to do ECT without an anesthetist. And that's what we wrote back to them, but they still want they want a document or a paper showing that we must do this. I mean, I just escalated it to our psych management group and said, listen, you guys as a whole must deal with this because it's too ridiculous.
Yeah,
But I mean,
motivation
what
for an
we have.
assistant laparoscopy for sacrocolpopexy. Why do you need an assistant to hold the camera? You can hold it with your teeth. I mean, I don't
Yeah, but it does become ridiculous, Steve. I mean, it's preposterous, these lies we have to tell. And I'm happy to tell the lies because you can either lie to the medical aid or you can help the patient. You can't do both. So, you choose your poison. Pick your poison.
Absolutely. But then picking the poison has an impact on you. It's not without impact on, our too many work hours, the lack of control or the autonomy, other colleagues who maybe don't respect us, who don't respect our expertise. It's a problem. So,
Dr.
lack of,
Bobby?
yeah, 20 minutes.
This is just a reminder, yes.
Okay, I'll start wrapping up. So lack of respect is a problem, and not just from colleagues, but from patients. Don't you find patients are getting less and less respectful with time? I mean, they treat it like you would treat your hairdresser. They're demanding. They've done their research. They've Googled for 5 minutes while sitting on the loo, and then they come to you and say, I've done my research. The negative reviews, I mean, I think all of us have been trashed on Google reviews at some point or the other, and Google won't take that review down. The patient can be.
They don't take it down.
No, not you. I mean, you've got great reviews already.
Me?
Yeah.
I don't know about you, but the
Yeah.
whole is,
Yeah.
you've got no recourse. If they say horrible things about you, there's absolutely nothing you can do.
So it leads to burnout and it leads to depression. So how do we prevent burnout? So the slide on I think the left, I don't know which side it is on your screen, but the one that says how to prevent burnout with the pictures. Simple things: exercise, balanced diet, good sleep habits, and then ask for help if you need it. And this is really, really important. And the one thing that I really want to emphasize is exercise, because even 7 minutes of exercise a day are very important in preventing depression. So, I mean, if you do one thing, go and do your 7 minutes. The New York Times has a whole 7-minute exercise regime, which is actually pretty easy to do. And that has been found in clinical trials to have a significant impact in preventing depression. Obviously, the more exercise you do, the better. But given how hard we all work, sometimes that's hard. Then I put the other one down because I thought we needed a laugh. How to avoid burnout. Try not to take work home. If necessary or urgent, stay late. We stay late anyway. I mean, who goes home at a normal time? And it says, my favorite one is put work concerns into perspective by having a day when you never work and having quiet time for reflection. I don't know who wrote this, but it was funny. But the one thing I do say is rely on your team and support each other. Have a team, have a support group. It's really important. But more lasting ways to present burnout is society. I mean, all our professional societies do this to bring about change in the societal perception of illness in doctors. To let people know, to let doctors know, it's okay, you can get ill, we'll treat you. I mean, you can have formal groups, like in your case, SASOC, but informal peer development programs. So I have a lovely group of lady psychiatrists, and we meet once a month to talk about cases. But we also meet to talk about things like, geez, I had this awful patient yesterday, and he was so rude and it upset me. And it's just nice to have a space to decompress. To be a patient, I'm going to skip this just in terms of time. But just remember that you want to hand over care. That's really important. And the last point, get a good medical aid, because it's really stressful on your doctor when you have a bad medical aid. So who is the impaired practitioner? So the impaired practitioner goes beyond burnout. This is a doctor who can't do their job. And it's physical, mental, or substance related. and it's mandatory to report. And the problem is that we want to choose between the privacy of the practitioner and the safety of patients. Having an impaired practitioner, I mean, I've dealt with several impaired practitioners. It is a hell of a stressful. And the reason that I really wanted you to look at this is it's usually psychiatric, it's substance abuse, it's mental illness. These are the things that really lead to impairment. So this is the HPSA stats on what leads to impairment in doctors. And why don't people get care? They're in denial half the time. They don't believe they need professional care. They diagnose and treat themselves, and they go for like quick coffees with colleagues to get advice, and they don't get actual proper care. And what does it mean when someone is impaired? That the 4 areas are knowledge, judgment, attitude, and care. And impairment in any one of those areas is an impaired professional. I said impairment is physical illnesses, mental illnesses, substances, a combination, and this is where we have impairment in judgment or ethical conduct in relation to patient care. When do we have to report someone? Okay, we ideally don't want to report. We want the person to report themselves. They have to self-report. But try and discuss it with your senior colleagues, and if it's really tough, get an MPS opinion. I'm just going to skip this slide. I just want to say that we have a duty to report. If the person doesn't self-report, we have to report. And who do we report to? The health committee, which is a non-punitive body. They undertake informal assessments. They make resolutions with regards to impairment, and they propose treatment and rehabilitation programs. And they're non-punitive, so they provide care. For those of you who work in medical schools, often impairment starts in medical school. That's when you start seeing it. So pick up the warning signs and encourage your students to go and get care. I just want to discuss a case this is a real case. Dr. B has been self-prescribing Tramoset, and the pharmacist phoned me to raise concerns about how much Tramoset Dr. B has been prescribing, because he knows that Dr. B has seen me at some point as a patient. Dr. B takes time off work. We discuss issues with the colleague, and the question is, should he be reported? Unfortunately, yes, Dr. B has to be reported because he's abusing the prescription. So he needs to either report himself, which is the desired option, or we, together with other colleagues, need to report him. Let's just skip and see. And I just want to talk again about what it feels like to be the carer. And it's the one in the middle that I want to talk about. We internalize our patient's distress. We take on the stuff. And when the physician is the patient, we take it on even more because it hits close to home. We identify with these people. They're our colleagues. We care for them. So caring for colleagues is a high stress process. It's our challenge to our expertise. It's our challenge to our boundaries. And the real challenge to us to remain professional and not be so distressed by what's going on so that you can't manage the patient. Are you a doctor's doctor? Is it a burden? Is it an accolade? I'm a doctor's doctor, and while I'm very, grateful that my colleagues think that highly of me, I would have to say it is a burden. It's hard to treat other doctors, but it really is. It's also a great accolade that people think you're good enough to actually come and see you. The one thing you do realize is that when a doctor comes to see you, they're probably not going to ever refer to you again. So just bear that in mind and take that. So just in conclusion, I want to say that managing the physician-patient is complex. Boundaries and good communication are key, because if we don't have that, we burn out. And to remember the HPCSA rules around impairment. And we actually have some time. So that's all from me. I don't know if you guys want to have any comments.
Thank you so much. It's absolutely wonderful to hear a person that can speak as you do and affirm our imperfections and help us along these actual problems. We do have 1 or 2 questions, if I may just start with Joy Masuki. Joy says, probably in the future, they will use blockchain technology to ensure privacy of data. We shall see. Steve, you clever with computers. What's blockchain?
I think that question goes to Bobby, to be honest.
Oh, do you know what blockchain technology is?
Blockchain technology exists. I know it's got something to do with Bitcoin, and I have no idea.
Bitcoin. Yeah, I know it's Bitcoin, but I don't know what else is.
No, but blockchain technology was important in the development of Bitcoin, and that's all I know about it. How it relates to privacy, I have absolutely no idea.
Okay. Yeah, you know, another point over here is payment of physicians. I had an operation recently, and the surgeon was such a wonderful person. He didn't send me a bill, and there's nothing I can do to get a bill out of him so I can pay. Now you can say, well, I'm gonna just give him a gift. The problem is this: you can't really give a guy a gift if he's done an operation. I mean, he spent an hour doing his operation on you, and I can't give him a bottle of wine. To start with, he doesn't drink. And secondly, there's no way of compensating a person in that way for the expertise and the time and the care that he's taken over you. I suppose if he bills you, at least you get the money, or the medical aid pays, and you get some money back from the taxman. But if they don't bill you, you sometimes are in an invidious position.
Yeah, it is complicated. But I agree with Bobby. I think, especially for your staff, I think it's important to have a consistent approach and be quite clear about how you're going to do it. Because I think the problem with these kind of patients is when there becomes a little bit of ambivalence and you don't have a clear directive from the very beginning. So I think it's important to be clear from the beginning how you're going to play that specific, billing process. And yeah, it's important to know. But I mean, it does change depending on your relationship with the person. There's another question from Gerard Ton. Is post-traumatic stress disorder common with doctors?
I think post-traumatic stress disorder is extremely underdiagnosed. I think it starts in medical school. And I think that many, many doctors have post-traumatic stress disorder. I think as a profession, we suffer from some forms of traumatic stress. I mean, our work is hard. I see a lot of it in medical students, and I think we don't do enough to protect medical students. I mean, as a medical student to go into trauma and, especially in a big teaching hospital, we know what the traumas look like. They can be very difficult for them. Even seeing a postmortem can be, if you're not prepped, can be quite traumatizing. But even for us who've been in medicine for longer, there are things that happen that trouble us, that are traumatic for us. And I don't think it's one single incident, so classically post-traumatic stress disorder, there's one thing, you feel your life is in danger, and that sets it off. I think with doctors, we have what they call complex PTSD, where it's a series and an accrual of events that actually lead to post-traumatic stress disorder.
Yeah, Bobby, on this point, it was highlighted to me quite clearly when I'd been working as a registrar for a long time in South Africa, and then I went to the UK to work immediately afterwards. And we had quite a bad traumatic delivery of a baby, and about a week later, one of the midwives came and said, "Yeah," we started talking about the case, and then she said, "But how are you feeling about this case?" And I thought, what? Someone for the first time has asked me how I'm feeling about quite a complicated delivery, and I think it's something that we routinely just think that people are going to be okay going through a very traumatic experience with a patient, and not really worrying that maybe the doctors are experiencing pain. And I think that's a very important question that Gerard's asked. It's not something that we embrace or even think about. Maybe it's changed.
Steve, it's absolutely true. When I was a young man, I used to be a pilot, and I knew other pilots, and the one pal went to fly for SAA. And on one particular time, I phoned him up and asked him how he's doing. He says he's on 6 weeks leave. He's not allowed to even climb into an aeroplane because he was stressed, and he was given 6 weeks of paid leave. And I've never in my life heard of any doctor ever been given any paid leave because of the stress that we've been experiencing. Yeah. We are actually disadvantaged in that way, is that other people, other professionals get paid leave when they're stressed, and we don't. Yeah. When we just as well have lives in our hands just as much as an airline pilot, and these guys get counseling, weekly counseling, and 6 weeks of leave just to get back to earth, if you see what I mean.
I mean, think about those days as a registrar. You have a traumatic delivery, it might even be a maternal death, counsel the family, and then you're straight back to labor to go and do the next C-section, and no one really cares that maybe you're not really fit enough to be doing that.
Well, I don't know if we have the capacity in our country
the
or
problem,
in our profession to offer this sort of service, but it certainly does seem, and I'd like to hear what Baby thinks about that.
So I don't think we have capacity, and I think it's a problem. I think it would be great if we could have counseling and debriefing services, but I mentioned professional development groups, or PDP groups or peer support groups. It's really, really helpful to have a group of colleagues that you meet with on a regular basis to talk through difficult cases. I mean, we all do it informally. We chat to our colleagues, but you have a specific time set aside to talk through it is very helpful. I mean, one of my colleagues had a suicide recently, and for us, suicides are very traumatic.
Sorry,
and she was
one of your colleague, what?
She had a suicide. A patient committed suicide. And for us, so we don't deal with death a lot. We deal with a lot of morbidity, but we don't deal with a lot of mortality. So, and I think also suicides by their nature are distressing. So she was very distressed, but we were able to support her and talk her through it. And that was sort of really helpful. It's also, on a lighter note, it's really nice to go out with your colleagues once a month and have a glass of wine and just sit and gossip and pretend that you're going out for work purposes. Tell your husband, you cook tonight. I've got a peer support group.
Yeah. Well, I'm very fortunate. Like, as my wife's a gynecologist, and if I don't know what to do, I can ask her, and sometimes I think she's right. And although it does, but this again, this thing of non-professional sort of amateurish support that you have to cling to, because we don't have formalized support assistance like the airline pilots do. But I can't see it happening. I can't ever see it happening. It's been around for years, and it's going to carry on. I mean, we were taught, and we will be teaching our medical students the same thing. You kind of fly by the seat of your pants.
But speak for me, it's sometimes, and maybe during our training it was worse, but I mean, there was occasionally a blunting of how people perceived your own stress, etc. And that may be something that needs to be sensitized at a more senior level. But I mean, and I'm sure you are involved in those conversations at the university as well, Bobby. But that there is often a systemic issue that I noticed when I went to the UK, where I realized we're a lot more sensitized to these issues. Yeah. But it's maybe a separate conversation.
No, that's true. I remember when you have an operative death, you can't put the person in a gurney somewhere and then carry on the list. You're meant to actually, when I was in the UK, that happened. They'll cancel the list and said, you're not operating, you've just had a death. You're not going to carry on. You're going to go home. And that's the sort of thing we must be. It can't happen over here, but it should happen. What do you think, Baby?
I definitely think so. I think that we kind of have this internal thing, just suck it up and go on.
Yeah, suck it up.
We just, as you said, we shove it to one side and we just keep going. And I think a lot of that is because of the patient burden. There are so many patients to be seen and so much to be done. But really, we shouldn't. We should take time for ourselves to actually process the emotion, not just for ourselves, but also for our other patients. Because if you've just had an operative death, if I've just taken a call about somebody who's killed themselves, you're not in a good space to deal with the next patient. You should actually have that time to process it so you can then work with the next patient properly.
No, you're absolutely right. I mean, I had this once when I had a woman that died of ovarian cancer, and we had to find places for all her children. And the next patient is a guy with piles, a woman with piles. And all she could do is talk about her piles. In the end, you feel like saying, listen, take your piles and stick them up because you've been having a terrible day. People have died. You've had really profound psychological problems. It does affect you. And the next patient, all they can think of is their piles. And that's that's again what you're saying. See, it's the suck it up scenario that is so damaging. But sadly, we've come to the end, Baby. We're going to have to wrap it up, sadly. And thank you so much for raising these issues. We should all have professional counselors that can deal with our issues. Steve, would you like to thank Baby?
Yeah, absolutely. Thanks so much. I think you've raised such important issues that we don't talk enough about. And thanks so much for your time. It takes time to prepare, and make yourself available for this talks, but absolutely great to have had you, and we really appreciate it. And thanks
Thank
for
you so much.
Yeah.
Thank you. It was really a great pleasure to be here.
Thanks,
Okay,
Bavi.
all
And
right.
just to remind all our delegates that next week is contraception. We're looking at the options and making contraception work for your patients, and that's sponsored by Bayer, and our talk is by Professor Zozo Nene. Thank you so much, Bavi. It's been wonderful having you. It would be wrong for me not to thank Steve for the use of your minibar, Steve, in the office here.
Pleasure.
And safe home, everybody. Safe home, everybody, and see you all next week. Thank you,
very
Bavi.
much. Thank you.
Thank you. Bye-bye.